morning, everyone. Can we have the slides? So today the topic that has been given to me is about ruptured aneurysms. Is balloon mandatory during EVT or not? So I would say that all of us who are doing intervention here know the value of a balloon during treatment of aneurysms. Still, just to make a comment that it was started by Dr. More in 1997, and there has been no look back since then. There have been multiple balloons which have come over the time, and they are really navigable and trackable. But using balloon needs training, and using balloon needs some kind of experience, because if not properly used, it can itself cause a lot of problems, and because of which people become deterrent of using the balloons. So I would say we should use more and more balloons. I am an advocate of using balloon for treatment of aneurysms. It not only does scaffolding of the neck for the ruptured aneurysms, it's a life savior in difficult situation. It gives you a stable microcatheter tip position in difficult aneurysms, especially if fundus is looking backward. It allows you to do good packing of aneurysms, protection of branches incorporated by the aneurysm neck, and we can use balloon for balloon wall technique for negotiation into difficult aneurysms. It can also do angioplasty in severe spasms. So I will start with a case where there's no balloon. So here is an aneurysm which is looking like, okay, I have gone there, I can do it, so why should I use a balloon? Look at it carefully. So there is the neck, though it was narrow neck, still the neck is filling, and there is some filling of the aneurysm as well. So we have treated the aneurysm, but we have not done cure for this aneurysm, and there is very high chance of recurrence. So I can do it. I can treat a patient with a catheter and a coil and a wire, but I have not used a balloon. But one day comes like this. This is very early in my life. It came when I just became a lecturer. I was doing this case, and it was a very small ACOM aneurysm, and as we are trained to keep a balloon, we kept a balloon and catheter. And as I was packing the aneurysm, I felt some resistance. I thought I'll take a shoot, and I took a shoot. Look at it. There is extravasation of contrast. And you know that if you don't have a balloon here, saving this patient is out of question. Balloon was there. I immediately inflated it, just continued packing the aneurysm, and in no time, the aneurysm was coiled, and this was the outcome, and patient walked back home. This was all possible only because of an aneurysm, of a balloon there at the neck of the aneurysm, so that you can control the bleeding immediately. I'll show you another case, because as we grow in our life, we learn from our experiences. So this is another patient whom I was treating on a Sunday. So this is a small aneurysm. Patient had sylvian subarachnoid hemorrhage, and it's a small MCA aneurysm, as we can see in lateral view, nicely visualized. And there's another unruptured aneurysm on the supraclinoid ICA. Okay, different projections opened up, and finally, as I always do, I took a balloon and a catheter. So catheter was taken into the aneurysm. You can see the sac is very small, and that too little posterior. So I was pushing the first coil, and towards the end I could not push this much of coil. I thought, let me take a shoot, and look at the shoot. So there's blood in the sylvian fissure. So it is alarming. You immediately inflate the balloon. The balloon is there only. I inflated the balloon. It was a Sunday, not much images were saved. And you can see the blood all over in the sylvian fissure. This is the blood in the sylvian fissure. We have to identify it. So I continued packing the aneurysm and inflated the balloon, and I could control the bleeding. This is the final picture where the aneurysm is fully coiled and there is no bleed. So the blood pressure, heart rate, everything was all good. I thought looks good. I did a CT scan. CT scan showed little contrast, but not much. I got super excited. I said, catheter is there. Let me treat this balloon also. I'll put one coil here also. So I put the coil, and after I detached the coil, the base of the coil started moving. And in no time, the coil was coming out. But I had a balloon there. So I immediately, again, there were not much images saved that day. So I inflated the balloon. I pushed the coil there. In the meantime, we prepared for the stent, and a patient who has bled just recently, though it was packed with the coils, I had to load the patient and start tirofiban and put the stent. The coils were pushed back into the aneurysm. And this was the final picture. The patient did very well. We have done her control MR angio and the control DSA as well, which I don't have here right now, but both the aneurysms are well obliterated. So these two cases itself tell a lot about the importance of balloon in the role in the life of a neurointerventionist. So I would say that a balloon should be there while treating the aneurysm. So I would recommend doing a balloon-assisted coiling every single time. So I'll show cases where balloon has helped in different ways other than just saving lives. So this is a routine, a PCOM aneurysm with fetal PCA. This is mainly for the junior people here, that you should treat every single case with balloons and coils. And you can see with the help of balloon, we could pack this aneurysm so well. There is not even a drop filling at the base. And this packing can be achieved only with the help of balloon at the neck of the aneurysm and the stable occlusion over the ears. Another patient looking like straightforward ACOM aneurysm, antero-inferior. So look at the fundus of the aneurysm. Many people will think I can do without a balloon, but yes, if you see with the help of the balloon, the packing of the neck is really good and you can achieve results like this, which is sometimes difficult without a balloon. Now, as the angle of the aneurysm changes, it becomes difficult to hold the catheter, and then you definitely need a balloon to even start the coiling. This is a basilar tip aneurysm. In AP, it looks like a straightforward, but if you see the lateral, the fundus is posterior. You cannot go deep into the aneurysm sac, and you have to inflate the balloon to pack it like this. So when it comes to wide neck aneurysm, anterior communicating aneurysms, they are the commonest. Look at the wide neck aneurysm, and without balloon, treating it in acutely ruptured is not doing justice to aneurysms like this. You take it along the branch you want, which can save. We have very beautiful hyperform balloon. Even if it is equally dependent on both the branch, you can keep in any one branch and just inflate at the neck. You may not inflate into the A2s. Inflate at the neck, it gives a proper hyperform shape, and then pack the whole aneurysm, and this is the final picture that you get. It clears, completely occludes the aneurysm from the circulation. This is the shoot from both the ACAs. So a case like this, a patient has two aneurysms. The ruptured one is the right MCA, ACA is the unruptured. We don't want to give antiplatelets right now. It's extremely wide neck, incorporating the two trunks of the MCA. So we put a balloon in one of them, inflate it. Here, the first key is to form the first 3D loop of the first coil should make a good basket, and once you have got a good 3D basket, then you can just keep filling in the basket, and maybe you can do a definitive treatment later on. At least the risk of rupture is taken care of, and you can get good occlusion of the aneurysm in the acute setting. A case like this, where it's a wide neck, large basilar aneurysm, without the balloon to get this kind of packing is very, very difficult. So in wide neck aneurysms, if you want to do without stents and coils, you have to use balloon to pack the aneurysms. Sometimes you may deal with variation in the anatomy of ACOM fenestrations, and in those cases, you have to save the limb if it is important. In this case, it was a nice one. Even if one limb goes, the other limb would supply. But we had to save the ACOM and the right ACA, so we put the balloon on the right side and packed the whole aneurysm with the balloon assistance. So this is the importance of balloon-assisted coiling. Now, as we go to difficult angulations of ACOM, as we saw that antero-inferior is okay, but when we go to the posterior pointing or superior pointing aneurysms, you cannot take microcatheter deep into the aneurysm. They will be only at the neck of the aneurysm, and you have to do the packing of whole sac from here. So you have to use balloon right from the beginning, from forming the cage to packing of the neck. The entire thing has to be with the balloon assistance. And the best part here is, first I took the balloon on one ACA and I was packing, but I felt that the catheter is getting pushed to the lower side, lower part of the aneurysm. I want it in a different direction. You can change the direction of the balloon, shift it to the other branch, and then pack the remaining aneurysm. Now the balloon is here, and we pack the neck very well. You can see now the coils have been placed at the base of the neck, and this is the kind of result we get with this balloon-assisted coiling. Without the balloon, getting this kind of result, stable result over the ears is impossible. Even though if spasm is there, don't hesitate to use balloon. There's severe spasm. I've shown this case. It's a very difficult case. Superior pointing aneurysm of ACOM, severe spasm. You can see just taking the catheter and wire has changed the orientation of the artery. But if you are careful enough, it will not cause damage to the arteries. Inflate the balloon. It's posterior pointing microcatheter, and always look in both the projections so that you know that you are not perforating the wall of the aneurysm and get a result like this. Sometimes these small blisters, we feel like we should put stent and coils, but if we choose our coils wisely and inflate the balloon properly, we can pack these aneurysms. Even to keep the microcatheter inside, I had to inflate the balloon. The balloon is here. And then I start packing it, and the whole aneurysm can be packed, and this kind of result can be achieved even in wide neck small aneurysms by using balloons. And I would say that all the balloons are quite good, but sometimes when we want stable position, scepter really plays a very good role in doing balloon-assisted coiling. Even in small blister-like aneurysms, difficult A1, never hesitate to take a balloon. It will save your life. It will give you good result at the end of the day. So sometimes here I'll show you what we have done. It was extremely wide neck incorporating. So we take balloon in one of the branch and take the microcatheter in the aneurysm. It's sort of compartmentalizing the aneurysm. We pack. So when we started forming the first basket, it started indenting on the inferior trunk. So we bring the balloon on the inferior trunk, pack the aneurysm. Now we see one lobule is towards the superior trunk. We go to the superior, we inflate the balloon and pack the superior trunk. Then while doing that, I realized that the coil mass has moved towards the inferior trunk, obliterating the flow. So I bring the balloon back on the inferior trunk, inflate, and just leave it for, say, 2 to 3 minutes, and the coil mass moves inside. And you can see now that both the trunks are free and the aneurysm is completely taken. So all this can be done only by using a balloon. This patient also had another aneurysm on the posterior supraclinoid ICA parapicom region, extremely wide neck, but with the good coils that we have today, you can use large coils, make good cage. You can even use PC400 coils. They really make very good cage in wide neck, and you can pack them up with balloons. Similarly, it's the same thing. The most important thing is keeping the catheter stable within the sac and making the first cage. So we inflate the balloon, pack the aneurysm well, and this is the result with balloon-assisted coiling. So another patient which is extremely wide neck ICA top. Now we come to ICA top aneurysms. They are another aneurysms which are usually wide neck because they are right at the division of ACA and MCA. This patient had ruptured from this ICA top aneurysm with a small pseudo thing, but he also had another aneurysm on the ACOM which needed treatment in future. So you cannot put a stent at this point of time. You have to treat them with balloon and coils. See, the lateral view is so important that if you don't take care, the catheter, while putting the coils, can rupture the aneurysm. So you have to actually pull the catheter back, inflate the balloon well, and pack it with coils like this and get a good result in the acute stage. And you can do the definitive treatment later on. So another patient with ICA top, posterior pointing fundus. So here the important point in keeping the balloon is to keep the microcatheter stable at the neck. So we are into the aneurysm. The pseudoaneurysm is posterior. Don't take the catheter into the pseudoaneurysm, otherwise it will rupture. You have to work from where you are. Inflate the balloon. They are beautiful hyperform balloons. You can see the coil mass is draped around the balloon. And you can see here it is seen very beautifully, and pack the aneurysm, which looks very difficult and looks like you need balloon for this. So on this patient here, balloon plays a different role. Now it's the anterochoroidal aneurysm. Anterochoroidal artery is arising from the base of the aneurysm. We have to keep the catheter stable, all that. Okay, we did that. And now I detached the last coil, and I inflated the balloon to pull out the microcatheter. As the microcatheter was pulled out, I saw that the coil mass has started moving out. And you can see the last loop of the coil has started moving out. And now the anterochoroidal is arising from the base of it. And if it comes out, it will occlude the anterochoroidal. So these are very compliant balloons. You can overinflate these balloons. I overinflated it and left it like that for around 5 minutes so that the last loop engages in the remaining coil mass, and which it did. And this is the advantage of having a balloon there. If you don't have a balloon, you cannot control that moving coil mass or the moving coil loop, and you may end up either retrieving it or putting a stent. So to add in the list is, we have talked about the importance while coiling, but while negotiating into the aneurysm, which I call it as a balloon wall technique, this patient had bled twice before they came to us, and first time DSA was done elsewhere, reported as normal. When they came to us, we did the DSA and we found this pseudo aneurysm on the, a feeding artery aneurysm on the ICA. Here it is, you can see this is the aneurysm neck. Can you see it? And this is the big pseudo on that aneurysm. So entering into this acute angled artery is very difficult. So what we do is, we place a balloon and we go just distal to the origin of that artery and use that as a wall, and then push the microcatheter along the wire. So you can see that the balloon is inflated just distal to the origin. So it is too distal, I'll just pull it back close to the origin, yeah. So now you can see it is just at the origin of the artery, which is bearing the aneurysm. We inflate the balloon fully so that it forms like a wall, and then you have your wire inside the aneurysm, and now we can slide the microcatheter on this wire to enter the aneurysm. This technique we can use in difficult aneurysm, but we have to be very, very careful because catheter sometimes suddenly jumps when they enter. So we have to control our wire. You will see as it goes in, it will suddenly make a move. So you have to control your wire so that the aneurysm does not rupture. After that, you can pull the catheter back, the balloon back, and use it for stabilizing the microcatheter for finishing the coiling. So this was the final angiogram, and she's doing very well and been referred for radiosurgery now.
You have 1 more minute, ma'am.
Yeah. So in variation of the anatomies like basilar fenestration, they are usually wide neck. Using them is good. So sometimes, in cases like this, patient presented with severe headache, seizures, and vomiting. It's a giant partially thrombosed aneurysm of the ACA with a variation of the anatomy. There is bihemispheric ACA, so this is the ACOM here. From the left side, ACA is coming and supplying the pericallosal territory, and this is the partially thrombosed aneurysm. The balloon will not only help us to do the BTO because we are going to occlude the artery. This patient whose old scans were there when he already had a stroke in the frontal area, so we were not bothered about the little paucity that we had, and we occluded it, and this balloon helped us to save the small part of the A2 so that coils do not come into the ACOM and they allow the blood flow. And this is the final angiogram of this patient. And post-op, he did not come out of anesthesia, and when we did the Dyna-CT, we realized that he has bled again during the treatment, so they are very, very fragile. But fortunately, he woke up from anesthesia after a day, and he also walked back home. Because balloon was there, maybe during the packing of the aneurysm, the blood did not extravasate so much that the patient it would be life-threatening for the patient. So just the last case in this series, when Comaneci was available instead of balloon, we also use Comaneci for doing coiling of the difficult aneurysms, and it was really controlling it very well. So now, balloon is not only necessary when you are doing balloon-assisted coiling or just coiling. Where any coiling you are doing, keep the balloon in the lab, keep the balloon on the table. This was acutely ruptured aneurysm. I decided to do a stent-assisted coiling. It's a very difficult neck. You can see this is the one ACA, this is the other ACA, and the fundus has a pseudo-aneurysm completely reversing on itself. So I decided to do stent-in coils. And after the first coil, I had not deployed also. I felt some resistance. I thought, let me do a DSA, and the hell broke loose that day, and look at it. So it was terrible, but I had a good team, and I continued coiling with the same roadmap. One assistant of mine compressed the carotid, and the other prepared the balloon. Keep a hyperform balloon ready because it takes shortest time to prepare. Within a minute, balloon was inside. I inflated in the ICA so that the bleeding controls, and I was continuing coiling in the meantime. Then I took the balloon into ACA and inflated and finished the coiling, and this was the final angiogram. There was no bleed, the aneurysm was secured, and this was a CT, horrendous looking. We kept him intubated for a day. Next day, he woke up without deficit. This is his 6 months control angio. Aneurysm looking very stable. So it is the balloon which saves life, which is important that it should be there and your whole team should be there to understand the use of that balloon. This is his follow-up scan. To conclude, to be safer is a choice. And I think we should be, because it's a life of a person in your hand. Balloon provides a sense of security in endovascular therapy of ruptured aneurysms, which are already fragile. It's life-saving, and it allows good packing of aneurysms, hence good long-term results. Thank you very much.
Thank you, ma'am. I think we'll go on to the next speaker.
I have a certain question though, and I really, sorry.
Yeah, yes.
Rashmi, great presentation.
Thank you.
But, and we could discuss this forever. I do use balloons all the time, but I'm not 100% sure that I agree with everything you said there. You're both, we could discuss, and there are so many things, but I think in the beginning you mentioned that there was a little bit of filling in the aneurysm and that's not cured. I think that's quite misleading. Seeing a small neck residue on an angiogram doesn't mean that the aneurysm is not protected, and also doesn't mean that it's not cured. Let me finish. So I think that's one thing we need to be making sure people get that message, that small neck residue.
So I did not say that. I would like to make a comment here. I did not say that an aneurysm is not protected. If it is a ruptured aneurysm, you have taken the fundus, the aneurysm is protected. What I said is it's not cured. When it is not cured, it means there is a chance of recurrence in the aneurysm. So what I was trying to say that you should do a follow-up in these cases, and you should be sure that if it grows, you should be ready to retreat them.
Sure.
That was what I was meaning to say. If it went in a different way, I would like to
Sure.
correct it. And what I mean to say is that if you use the balloon, your chances of packing the neck becomes higher.
I agree with all that. I agree. The balloon helps you to pack. If you are in shade, it will help you to save. But sometimes balloon itself can be a problem.
Yes,
If you got
yes.
a blister dissecting aneurysm or some, balloon can be tricky.
Very
You're
true.
both pericallosals. I have to say, I don't use balloons in the pericallosal region at all because you rarely need it. Very rarely.
Even I don't use
And your
it.
rupture, so your rupture was because you had a balloon there, and that was your problem. I didn't understand when you had a rupture and you have coiled that, and then you went ahead to coil the PCOM. What was
Yeah, I
your
know.
rationale? Because you are then, and then on top of it, you put a
Give
stent in,
antiplatelet.
and then you have an antiplatelet in the patient.
So there is no rationale. It is just, it's like some days you think you can do it, and they are not your days.
Of
I should
course.
not have done it. It's a mistake, and you are like, patient is not having funds, and patient has come, and I have treated this, I have got a problem. So lesson from that case, which because of limitation of time, I could not say, don't do the next aneurysm if you have got a problem in the first. That was a lesson from that case. But what I wanted to show in that case here was not that I am very aggressive or this. What I wanted to show is that if balloon is there, at least you can do something. These are the potential things which can happen with you. And if a balloon is there, it can save. Yes, treating the second aneurysm was a big mistake that day. I should not have done it. Because I finished the MCA and I thought everything is okay, I thought let me do it. I will put one coil, and I was very confident that I'll finish it by putting one coil. I didn't have to do anything. But things can go wrong. Yes, things can go wrong. It's neurointervention. So you have to be prepared for things, and if one thing has gone wrong, don't go into the second one. It has happened. I have come out in a case. That case was not to show the vigor of a case or anything. It was to show that what balloon can do for you. It was a representation of that situation.
Thank you so much, ma'am. I think you can have the
Now we'll
discussion.
call